Good morning, everyone. This is a session today for HURAG that is intended to focus on cervical cancer prevention. However, our chair, Josie Norfolk, will update us on HURAG at the end of the session. But we have some very nice presenters who will be introduced to you in a little bit, and we really appreciate the generosity of their time. The session is being recorded, and it is just a good time for me to tell you that this is a high-tech operation with a low-tech operator, and so you're going to get what you get, but we're going to see how it all goes. So far, everyone has been wonderful at helping with that. Our goal for the session is to increase awareness about cervical cancer prevention efforts and the ways in which Rotarians can be involved. We intend to send a summary to the people who are registered for this session in a few days after the session. I can't wait to see how that turns out. And we do ask that you remain muted during the presentations if at all possible. We can stay around for a little bit. It's a very packed session, but we can stay around for a little bit and share some conversation at the end, perhaps 15 minutes or so. And if you put questions in the chat box, I believe that I'll be able to capture them and we can answer them in the summary, or we'll do our very best to do that. So with that, I'd like to introduce our chair, Josie Norfolk, who will start us off with an introduction.
Thank you, Carl. Good day, everybody. Good morning, good afternoon, good evening, etc. And welcome to our meeting. I'd like to give special greetings and thanks to Raju Sabu, who's the past president international, who's the past Rotary International President 1991-1992, and one of our HURAG directors. I'd like to also welcome and thank Brenda Cressy. She's from the Rotary Club of South Portland in Cape Elizabeth, District 7780. Brenda is currently a trustee of the Rotary Foundation and served as its first chairwoman in 2018. I'd also like to welcome Dr. Sharon Kapamwe, who's Technical Officer for Cancer Prevention for the World Health Organization Africa region. Sharon previously served as the Assistant Director for Non-Communicable Diseases in the Zambian Ministry of Health. And I'd also like to express my thanks and appreciation to our wonderful speakers, who Sheila Hurst will now introduce to you all. Thank you.
And thank you, and hello, everyone. In this meeting, we'll hear 4 experts describe programs, efforts, and organizations committed to cervical cancer prevention. First will be Dr. Isabel Scarinci. She's a professor and senior advisor for globalization and cancer at the O'Neill Comprehensive Cancer Center, University of Alabama at Birmingham. In addition to teaching, Isabel is very involved in community service and is the honorary consul of Brazil to the state of Alabama. A member of the Rotary Club of Birmingham, Isabel was part of a team funded by a global grant with the Rotary Club of Colombo in Sri Lanka, the Sri Lankan Ministry of Health, and the O'Neill Comprehensive Cancer Center to vaccinate girls in Sri Lanka against HPV and to screen women for cervical cancer. Rotary has recognized Isabel as one of the 6 champions of health worldwide for her cervical cancer prevention and control efforts in Sri Lanka and other low-resource settings. Her story is featured in the June 2021 Rotary magazine. The next speaker will be Silvana Luciani. Silvana is the Unit Chief, Non-Communicable Diseases, Violence and Injury Prevention in the Department of Non-Communicable Diseases and Mental Health at the Pan American Health Organization. That's PAHO, P-A-H-O. PAHO is the specialized international health organization agency for the Americas working to improve and protect people's health. PAHO is also serving as the regional office for the Americas of the World Health Organization. At PAHO, Silvana is working with ministries of health in Latin America and the Caribbean to better understand the burden of non-communicable diseases and to establish evidence-based non-communicable diseases programs. Silvana will discuss cervical cancer elimination as a public health problem and review the global cervical cancer elimination strategy. Next will be Dr. Melissa Miskel. Melissa is a board-certified gynecologist who has practiced in New Brunswick, Texas, for more than 20 years. In addition to working with patients, Melissa is also the executive director of the nonprofit organization PINC, that's PINCC, Preventing Cervical Cancer Globally. PINC's mission is to prevent female-specific diseases in developing countries. They use low-cost and low-technology methods to create sustainable programs through patient education, medical personnel training, and facility outfitting. Melissa will give an overview of cervical cancer worldwide and PINC's work in low-income countries. And our fourth speaker is Dr. Rita Kalra. Rita is a doctor of internal medicine and senior administrator at the Civil Hospital in Panchkula, India. She heads the HR department that has 1,000 employees, and she's responsible for infection control, upkeep of hospital records, and medical facilities, including the COVID isolation wards and an ICU. In addition to that, Rita is also very active in Rotary. She's past president of the Rotary Club of Chandigarh Midtown, assistant district governor of District 3080, district chair for preventive health, district coordinator for TB elimination, and she's also a HURAG board member. Rita will describe a project designed to help protect girls and women in low-income communities from cervical cancer using education, awareness, vaccination, and testing. Now, please join me in welcoming Dr. Isabel Sparinzi.
Good morning. Let me see if I can share my screen, Carl. If not, I'll rely on your technical support.
Oh, bless you.
All right. So good morning. I want to thank Carl for the invitation. And also it's such a pleasure to talk to all of you today as experts. I am just a little piece of this pie. So I label my talk today, cervical cancer elimination as a public health problem. Are we almost there? And I think we are. We're getting closer and closer, and I'm gonna share that with you. So my story is one of the best experiences in my personal and professional life. And you're gonna see throughout my presentation that is a story of friendship, academic, public-private partnership, vision, and the true spirit of Rotary, of serviceable self. And I have worked with wonderful, wonderful people. But before we start, I know everybody here know a lot about cervical cancer, but I think it's important for us to frame a little bit. When I started working cervical cancer, we didn't even know about HPV. So with the discovery of HPV, it really changed the whole way we manage cervical cancer, that we transition from the 4-stage more cytology approach from the cytology approach to more the 4-stage. Now we know from the natural history of cervical cancer that is HPV acquisition, and if they don't clear, that's when we need to start getting concerned because it can progress to precancer, cancer, and invasion. Once we understood the natural history, we came up with 2 tools, not we, others, not me. HPV vaccination and HPV testing. However, that needs to be age appropriate. So we do have cervical cancer is the only cancer that we truly can prevent with vaccination before the age of 15. And I'll talk more a little about that, and HPV for women 30 and older. So those are our wonderful tools that we have. Most of you know the recommendations in the US. It's recommended that girls and boys are vaccinated at 11 and 12. We can start as early as 9. FDA approved up to age of 45. Kids 9 to 14, only 2 doses, and kids 15 and older, 3 doses. In the research data, the recent research data toward 1 dose is looking very promising. So hopefully with the vaccine shortage, we can move to 1 dose. And then screening that we can start at the age of 21. Because we have HPV testing, we do not need to do it as often. And I'm going to mention a little bit the World Health Organization recommendation. So, but this is the recommendation, and one size does not fit all, because from a public health perspective, I spent my career on how to adapt evidence-based strategies and resources, and still address population health in the context of cancer prevention control. So Silvana will talk more about the World Health Organization recommendations, but this has great relevance to our project in Sri Lanka and other settings. And these are the goals for that it was released in November of 2020. Vaccinate girls by the age of 15. 70% of the women are being screened with HPV for us to transition from cytology to HPV testing. And of course, screening without treatment, I say screening without resolution, and following women all the way through, to me is not ethical. Whoever we screen, we need to be able to treat and take care of these women all the way. So Sri Lanka, I'm going to talk a little bit about Sri Lanka, and I'm going to try to allow time for the end if we have questions. So this, I'm going to give you a little bit of the history, because it is really a history of friendship. Very briefly, when they had the tsunami in Sri Lanka in 2004, our club made a donation. And Ravi Ravindran came to Birmingham to thank the Rotarians for the gift and invite them to go to their country. I was not in the club then. And of course, if he invited, they took him up on it and went. And that is where the friendship started. We started with the breast cancer. They donated mammography equipment to Sri Lanka. And then that's how O'Neill Comprehensive Cancer Center, we got involved, because my expertise is evidence-based strategies to promote screening. And then we expanded through cervical cancer. And then we have a partnership between the Rotary Club of Birmingham, Rotary Club of Colombo, Ashlock Leyland, and that donated the mobile units, that's private, the O'Neill Comprehensive Cancer Center. So we really came together as the evidence-based strategies. That's where we advise the group as the Cancer Center, the Sri Lanka Minister of Health, who plays a major role in this effort. Private, Ashlock Leland, that donated the units to us for life and maintenance, and Rotary Club of Colombo and Birmingham. And then with these efforts, and we got a grant from Rotary International to start our strategies. So, and our goal is for Sri Lanka to be the first low and middle income country to eliminate cervical cancer as a public health problem. And we are very much on the way. So as I mentioned, it's a true partnership. This is our one of the meetings with the Minister of Health, because for us was very important that we change guidelines and start with evidence-based and a very comprehensive level. Very simple strategies. The Minister of Health took up and start vaccination. Because of resources, we need to decide an age. We couldn't do all the girls or up to 15. We decide on 10 to 11 in collaboration with them. And what they have done is something that we'll never be able to do in the US, opt out in schools, which means parents need to sign a release if they don't want their girls to be vaccinated. So they vaccinated 80% of the girls in that cohort the first cohort in less than 6 months. And now every year, 10 to 11 until they catch up. The whole country transitioned from cytology to HPV testing. And as part of this grant, we went with COBAS. Because it's an island, that platform would fit very well for that country because they can maintain it. For other settings, like we're working the Pacific Islands, we are using Gene Expert, and I can talk more about that in terms of the platform. And also we capitalize on what they already have there. That is, they have the midwives that's equivalent to the community health workers, where women get a visit from a midwife at the age of 35 and 45, which is very consistent with the World Health Organization recommendation to get HPV testing at 35 and 45. So we're capitalizing on that. And women are going to only have 2 screenings in a lifetime, which has shown to be sufficient. And then we have the mobile units that will be fitted for the screening. So this is the first pass. The women who are very resistant, no matter what, then we are going to introduce self-sampling for HPV testing. We were one of the pioneers in developing this in the Mississippi Delta, and now we have expanded to other countries. Unfortunately, in the US, it's still not FDA approved, and that has been one of the major challenges for us, expand self-sampling worldwide until FDA approves in the US, because everybody looks at the FDA for guidance. So that's very simple. Vaccination, screening, maximize on the resources they have available. It takes a village. This is as you can see with the pandemic, we just joined them when the machine got there through Zoom. But that was done regardless of the pandemic, and we are very much on our way. So how can we get there? And this comes from ILREG, advocacy and education. We need to increase awareness, and then talk to our ministries of health, nonprofit organizations, and really social mobilization. I put that in dark green because I think that's a lot of where we should put our efforts. Of course, HPV vaccination, work with Gavi to support in low resource settings, screening, follow-up and treatment, and hopefully we will not need palliative care, but that's unfortunately part of the process. So the discovery and a lot of the science in cervical cancer has been done. We talk so much about cure, and here we have a cancer that can be prevented. And why should we do it? Because we are Rotarians. We see opportunities where others see challenges. And why do I believe we are the people to do it? And why am I committed to this? This is me. I had polio. I was 8 months old. I was born in Brazil. I had the first dose, and when the second dose came about, I was sick. And my mom, the doctors told my mom, well, we'll vaccinate her next month. And we had an epidemic, and I had polio in both arms and both legs. And my mom dedicated her life to going door to door. And she would take me and in very shorts and would say, you do not want this to happen to your child. She made me feel so important and part of a great mission. So when I was about 12, she said, we'll get way more done if we split. And then I was too weak to even carry the cooler. This is after some surgeries. And then my brother would carry the cooler, and I would go one way and she would go another way. And that's what we did all of our lives. And why is that important? It's because if you look, in 1988, we had 350 cases of polio in the world. In 2008, 20 years later, we only had 1,600. 99% reduction in 20 years. And you know this data, you're Rotarians. Was the polio vaccine that made the difference? Yeah, but not really. Because the vaccine became available, mandate by the World Health Organization, free to everybody in 1974. In 1988, we still had 350 cases. This is me. I was in Rotaract in my youth in 1985 doing the vaccinations. So what did it was Rotary, was not the vaccine. We had the vaccine. And people like my mother that made the difference and got where we are with polio today. And a lot of kids do not need to experience what I went through with surgeries. And I am one of the blessed ones that can walk with assistance a little sometimes, but I can do it. And other kids were not as fortunate as I was. So what is the relevance to cervical cancer? The numbers are increasing, are not decreasing. About 2 or 3 years ago was about 500,000 new cases. Almost half of are dying for a preventable cancer. And I just hope it will not take 20 years for us to change these statistics, because we do have the tools, and it's no longer in the hands of the medical community, it's in our hands, and it's up to us. And I put my email there because you can count on me. This is my mission. I owe this to my mother, that this is a quote from the Rotarian, if you read the article that they quote. My mom departed 2 years ago from breast cancer, knowing that she contributed to ending one disease. I hope when my time comes, I have helped to eliminate 2 deadly diseases. And I know we can do it. I know we can do it. So email me, I'll help any way I can. That's my mission. And I'll stay with it until I go. Thank you.
Well, Isabel, that's a wonderful story, and thank you so much. I've seen you do several presentations now, and each one is different and yet informative each time. And so thank you so much for that. Perhaps you can stay around till the end of the presentations, and someone may have some questions. And of course, as I said, they can put them in the chat and we'll do our best to answer them later. Thank you for posting your email. So now we're going to move on to a video portion of our presentations, I think, if we can make the technology work. And so if you will all be just momentarily patient, I believe this should come up.
Good morning. It's a pleasure for me to be here today to talk to you about the Global Cervical Cancer Elimination Initiative and how you as Rotarians can help lend your influence and support for this global initiative. Cervical cancer is a disease that is highly preventable. It's a very common disease, unfortunately, especially in low and middle income countries. Each year, 570,000 women are newly diagnosed with cervical cancer, and 311,000 women die from this preventable disease. This map shows in darker colors the countries that have highest incidence rates, where more than 50 per 100,000 women are diagnosed with cervical cancer each year, to a low of about 5 per 100,000 women in countries shown in lighter purple. Cervical cancer, unlike other types of cancer, has a known cause, persistent infection with high-risk types of HPV, and has a precancerous stage, so that infection, if it persists over time, will turn into precancer, and if precancerous lesions are not detected and not treated, will turn into cervical cancer. And so HPV infection initiates shortly after sexual debut and is very common in women in their adolescence and 20s. And if infections persist over time, precancerous lesions tend to appear in women in their 30s and 40s and 50s. And then cancer tends to develop in women in their 50s and 60s. And because of the natural history of cervical cancer, there is a comprehensive approach and various tools that are available to prevent the disease, starting with HPV vaccinations, which are administered in girls before the age of 15 years to prevent HPV infection. And in women in their 30s and 40s, cervical cancer screening is recommended, especially with high performing tests such as HPV testing and treatment of precancerous lesions. And women who are diagnosed with cancer, of course, need access to timely treatment and palliative care. And so when we look at cervical cancer elimination as being possible because of HPV testing and HPV vaccines, and we apply these strategies, we look at possible elimination, but it isn't possible with current approaches of HPV vaccination and screening. That is, if we look at the status quo of what countries are doing and rolling out with HPV testing and HPV vaccination, we will never get to elimination. So what we need is to intensify HPV vaccination, and we know that we will get to elimination eventually in 100 years by 2120 in most countries if we ramp up our HPV vaccination strategies. But if we couple screening initiatives, so screening with HPV testing coupled with HPV vaccination, we know we can speed up elimination and reach in many countries in the next 40 or 50 years. So a cervical cancer elimination initiative has been established with the vision of a world free of cervical cancer. This was presented to the World Health Assembly last year and adopted by all ministers of health. And so there's tremendous commitment and support around this vision and around the target of cervical cancer incidence rates of less than 4 per 100,000 women, and targets for vaccination of 90% of girls before the age of 15 years, and a target of screening of 70% of women with an HPV test at 35 and 45 years of age, and a target for treatment of both precancerous lesions as well as invasive cancer treatment of at least 90% of women who are diagnosed. So where are we in terms of reaching these targets? Well, we are far off, and much more work will be needed in order to reach these 90, 70, 90 targets. For HPV vaccination, less than half of the world's countries have introduced HPV vaccines as part of their national immunization program. And when we look at the countries that have introduced vaccine and we look at their coverage rates, as reported in this graph, we see that very few countries are reaching that 90% coverage. It is challenging, and much more investment is needed in order to reach that coverage rate. So some of the strategic actions that have been identified to reach that 90% HPV vaccine coverage target needed for elimination is to improve communication and social mobilization, especially to make the public aware that HPV vaccines are highly safe and effective to prevent cervical cancer. Many more campaigns are needed. There's a lot of HPV vaccination false information circulating, a lot of anti-vaccine campaigns. So we need a lot more effort and investment in communication and social mobilization to reach that target. We also need a sufficient and affordable HPV vaccine supply and to introduce it into many more countries, and to also expand the coverage through innovative delivery methods such as through schools and through primary care clinics and through community health fairs and through vaccination campaigns. For screening, many countries have introduced screening services since the 70s and 80s, but what we see is that the coverage rates are poor in most countries, and very few countries are achieving that target of 70% coverage. So again, much more investment is needed. And as we're promoting the use of HPV testing instead of the standard cytology or visual inspection screening test, what we see is that there's very little progress in many countries to introduce HPV testing. Very few countries around the world, shown here in dark blue, have introduced HPV testing. There are a few countries in light blue that are doing it in pilot programs with the view of scaling up to national programs, but more countries, as shown in gray, have yet to introduce HPV testing. So to scale up and achieve that 70% screening target together with the 90% precancer treatment target, again, much more communication and education is needed to inform women about the benefits of screening, about seeking preventive health services, even when there are no signs or symptoms of cervical cancer, to educate women and girls about the promptness of seeking screening services. As well, on the supply side, we need to ensure that HPV testing is available and affordable in primary care clinics, and that there's national scale up of screen and treat strategies in primary care services, including increasing the quality of these services. For cancer treatment, we know many, many women still lack access in public services, and that there are financial as well as geographic barriers to women accessing cancer treatment. And that target of ensuring that at least 90% of women have access to cancer treatment is going to require a tremendous amount of effort and investments, starting with reducing the cancer stigma and investing in health services across the continuum of care, and also investing in health workforce to ensure that the competencies are in place in the services. So just to conclude, status quo of screening and cervical cancer screening services is not an option. And those 90, 70, 90 targets are feasible with investments, greater investments in health services, as well as health education and community mobilization. And cervical cancer elimination is feasible, but it will require concerted effort, significant effort across all stakeholders with a strong focus on community participation and community mobilization. And we look to the efforts and support from Rotarians around the world to help build the momentum needed to make cervical cancer elimination a reality. Thank you.
My name is Dr. Melissa Miskell. I am the Executive Director of PINC, Preventing Cervical Cancer Globally. Cervical cancer is one of the most deadly diseases that is found in the world today, affecting women in low and middle income countries to a devastating number. The World Health Organization has stated that there were 337,000 women who died in the year of 2012, and by the year of 2030, this number will reach an astounding 450,000 women that will die that year. Cervical cancer is completely preventable. It is very easy to diagnose and very easy to treat. One reason that cervical cancer has become so prevalent in low and middle income countries is due to the HIV infection. HIV decreases the immune system and makes cervical cancer much more prevalent. These countries that have been overrun with HIV are the ones that have the most population of women that have cervical cancer. So even though we're very good now at diagnosing HIV and having medications available that are affordable and treatments that are extended worldwide, the problem is that these women are being saved from HIV just to die of cervical cancer. Cervical cancer is not screened for in the majority of low and middle income countries. And it is a very easily diagnosed in a precancerous condition called cervical dysplasia. PINC is an organization that teaches healthcare workers in low and middle income countries how to recognize cervical dysplasia and treat it. Cervical dysplasia can be recognized very easily with a process called VIA, visual inspection with acetic acid. This is a very inexpensive type of diagnostic procedure that can be taught to anyone who can do a speculum exam. Once this is taught and healthcare workers in low and middle income countries can recognize cervical dysplasia, then it can be very efficiently treated and effectively treated with a thermocoagulation device. This treatment takes 20 seconds and is done in a see and treat setting. So as soon as the patient is screened and diagnosed with cervical dysplasia, they can be treated in that exact same setting. PINK takes small teams of healthcare workers into low-income areas where there are healthcare workers that desire training in VIA and thermocoagulation. This is a very easy way for us to screen and treat 100 women a day. And in that instance, we will pick up approximately 10 to 12 cervical dysplasia lesions. These lesions are treated then with thermocoagulation, and these women are then brought back in 6 months when PINK returns to the same area and does another screen and treat camp. If these women are still diagnosed with dysplasia, they can be treated again with the thermocoagulator. We train healthcare workers in these settings so that they can screen and treat their own populations. And once they are trained, then we leave our equipment for them so that these clinics are self-sustaining. PINK has been in approximately 10 to 12 different countries. We have active clinic sites going on in all of these countries where our healthcare workers have been trained. They continue with their screening. These clinics have all had thermocoagulators donated to them so that they become self-sustaining and can treat the women that they are responsible for in their own clinics. PINK's teams consist of healthcare workers made up from physicians, nurse practitioners, and support personnel that help us to run the clinics where we usually stay for a week. We really enjoy having volunteers come with us that are not medical so that they can learn what we do and understand more about cervical cancer and its relation to HIV and really to world economics. The women who have cervical cancer are usually the main providers for their families. They are the ones who take care of the children. They are the income breadwinners. And when these women die, it's devastating to these communities. The children become orphaned or have to be cared for by another family member. The income that these women bring into the community is lost, and this in and of itself makes it a global economic problem. The cost to train one of these clinics really is not that much. The vinegar that we use is not expensive. The supplies that are used are also found generally in the clinic. The thermocoagulator is the biggest expense for these types of trips. The thermocoagulator itself is quite remarkable. The product that we use is made by Liger Medical. It is a handheld, portable, with a rechargeable battery that can be taken into any clinic setting, used, the probe changed out, and then used again just a couple of minutes later. The thermocoagulator costs $1,500 and is something that is life-saving in many ways for these communities. The thermocoagulator works by burning the end of the cervix where the cervical dysplasia or the abnormal cells are. The probe heats up to 100 degrees Celsius and then is placed on the cervix for 20 seconds. This in and of itself is an amazing piece of equipment because it replaces cryotherapy. Cryotherapy is how we used to always treat cervical dysplasia. Cryoguns are very easily damaged by the contaminated gas that comes from the CO2 or the nitrous oxide tank. These tanks are very large and quite expensive to fill and not at all portable. So the cryogun has become basically obsolete, even though there are thousands of them all over the world. They have been rendered useless in most places, and the other problem is they are set in places, but no training is given for the healthcare workers there to be able to use them. The thermocoagulator is much better in so many ways, mostly due to its portability and the ease of recharging the batteries. The probes come in different sizes and are easily interchangeable. They also are easily disinfected. So we have changed to thermocoagulation in our training for every site, and are at this point going back to sites where we trained with cryo and replacing their cryo guns, which most of the time are useless, with a thermocoagulator. We're very accessible to these sites. They can call us with questions. We can replace any damaged parts if there are any that occur. We have several sites where we have donated our thermocoagulators, and these places will keep statistics on how many times they've been used and how many more people they want to train. It is very exciting to go back to sites where we have trained and see the healthcare workers there so excited about being able to treat the women that they're responsible for. One of the other main things that is important to PINC as a group is that when we do train healthcare workers in these low-income countries, that we make sure they're trained well enough that they are also able to train by the time we leave. That way, they are making their program even more sustainable. They do have the equipment, but they also have the knowledge to train other healthcare workers in their clinic or in other facilities that they may have access to. PINC's funding comes completely from volunteers and donors. We have no one that is on salary. We all volunteer our time and money as far as getting to sites and training and supplies. We've been very fortunate to partner with Rotary International in the past. We have 2 grants, one in Kenya and one in Nicaragua, that we have completed. We have also been fortunate enough to partner with local Rotary clubs as well. They have donated money to purchase thermocoagulators, which we can then leave in villages so that these clinics become self-sustaining. PINC has several ongoing sites throughout the world, but due to COVID-19, those have been halted for the past year. Our goals in the next 6 months are to get these sites up and running again and to start new sites as we're approached by more countries. Hopefully, PINC's initiatives will dramatically decrease the mortality rate that the WHO has predicted by 2030. I just had the guy that we trained in Kenya, at Matibabu, who emailed me, and he's like, can you come back and train and bring more? He's like, there are so many women that need this.
हम जो है सहायता संस्था चंडीगढ़ में काम करते हैं और कैंसर पेशेंट्स की हर तरह से मदद करती है।
So now we have to find a way to. So Rita, you had a few comments for us. Rita's still here? I know she is. And we can't hear you. Are you muted? Try again. Oh, I can't hear you. Can anybody hear Rita? Oh, we have a very nice video. No.
I must say, Rita's rendition of the Jerusalem was very good.
It was. Oh, Rita, we still can't hear you. So as you work on that for just a minute, I would like to tell you that our friend Rita Kalra is an amazing woman who's done wonderful work in India in many areas, including tuberculosis and cervical cancer prevention. And we first met her several years ago at a Rotary convention, and for her, I think Rotary is a family activity, and that's about all the story I can share right now. So I think Rita is trying to log in on a different source. And for some reason, we're not getting your sound, Rita. So
can you hear me now?
Now we hear you.
Yes.
Oh, welcome.
Okay. So good evening all. It's an honor and privilege for me to be addressing a gathering of stalwarts and professionals from URAC. I'm deeply indebted to our chair Joshi and director Karl for giving me this unique opportunity to speak to you all about Project Astha for immunization of girls with human HPV vaccine from EWS families. While we were all waiting for the COVID vaccine to shield us from the pandemic with queries about efficiency, efficacy, duration, here we had a 100% efficacious, lifelong protecting vaccine, and we were wondering whether to go for it or not. We all know that cervical cancer vaccine is the only vaccine available to prevent cervical cancer. We also know that cervical cancer remains one of the most common cancer and cause of cancer-related death in women across the globe. We also know that 85% of these women come from low and middle income countries. Then why, my friends, why are we so indifferent to this cause of saving lives? The huge burden of cervical cancer-related mortality is due to decades of neglect by global health community. However, with an ambitious and inclusive strategy, we can accelerate elimination of cervical cancer as discussed by the speakers previous to me. We can rewrite the script with Rotary and public health collaboration and make the world once again free of cancer. Well, friends, the wheel has been set rolling as you saw in the video. It has been a strong and a beautiful evening. We will not get into the statistics. You know why? Because it is depressing and we need to focus on preventing. We have talked about the problem. We know the problem. We just have to act now. Each one, reach one, and save one every year. We are all, you know, you are all wonderful people. You have been a tremendous source of strength with valuable presence on this virtual platform. Tonight, I urge you to take this strength home and change one life, one opinion, and the world will change on its own. So, for a future free of cervical cancer, let's support HPV vaccination campaign all over the globe. Thank you.
Thank you, Rita. And what a wonderful presentation. By the way, I took the time to do a little background reading about your hospital district and the operation you run. And you are an amazing woman to even have the time to share with us today. So thank you very much. At this time, we'd like to ask our chairwoman, Josie Norfolk, to give us a little update on HURAG and maybe where she thinks she's going to take us for the next period of time.
All right.
Thank you, Carl. I have to say, I agree with your comments about Rita. She's amazing. I don't know how she has the time to do anything. She's wonderful. And if you'd like to read about her, if you go onto our website, she's there on our website. I did a blog all about her. So, okay, HURAG. We are trying to update, refresh, and grow HURAG. And I think quite coincidentally that Zoom is actually helping us to do this by enabling us to have meetings such as this, and for the actual board of HURAG to have more meetings and more discussions and more planning sessions, which we have been doing. My vision is to grow HURAG, to grow the membership, and to have members in every Rotary district of the world. We at the moment, we're in the process of forming a chapter of HURAG in District 2452, which consists of 129 medical personnel from 9 different countries. The nine countries make up the district, and this is in line with RI's latest policies about RAGs, that we can actually now have a chapter of a Rotary Action Group in a separate country. So, you know, Rita, get to work there. And I'm sure that we can do this in many countries. And I see Harry's here, Harry Wang. I'm sure he can organize one of these chapters in China. He's also a very hardworking chap. We've also welcomed the RotaCare free clinics. They've now come under our banner, and they're in the process of becoming one of our areas of emphasis. We've updated our website and we've updated our Facebook pages, so please go and have a look at those. We've also updated our membership applications. The process is now much easier. You can go to the website, you can fill in the application form. There's no cost involved. And please encourage your friends and fellow Rotarians to go to the website and have a look and join us. I'm also trying to establish a signature event, a so-called Well Women's Day, to be held around International Women's Day every year in March, in which way we can Rotary Worldwide can then sort of every club in Rotary can then sort of concentrate on having an event held around this time with this concept. And as you can see, health education is really it's something that we need desperately, not only for cervical cancer, but also for breast cancer, for heart disease, and all the things that affect mainly women, because women actually are the backbone of every family. And if the woman isn't there, the family falls to pieces, the family falls to pieces, the health falls to pieces. It's a very expensive, very expensive thing to lose a mother in a family. Apart from being an emotionally expensive thing, it's also economically a very expensive thing. So I'll be contacting all the incoming district governors to introduce this concept and to see whether we can actually get it to fly in the next year or so. And I'll also be sending you all the details about these things. We do have a virtual booth at the virtual convention. So if you are there, you could virtually pop in and give us a virtual visit. I must say both Carl and I have been on quite a learning curve in the last few months, but I think maybe that we're getting there. Thank you.
Well, thank you, Josie. And I have to say that I am very appreciative of all of our presenters today. They have the generosity of their time.
Wonderful.
Is just wonderful. It is appreciative. And as you can see, I'm really trying to struggle to get this this last slide up here. So our goal today, of course, was to increase awareness and to motivate Rotarians to get engaged in the issue of cervical cancer prevention, and also to reinforce our membership in HURAG. I'd like to thank our presenters, of course, Isabel, Silvana, Melissa, Rita. These are wonderful people who dedicate so much time and energy to this work. And I have to tell you, this has been a project for HURAG for about 7 years now. And I would say we really launched out of a meeting that Sheila Hurst and I attended in London. Now it seems like a long time ago. It was a November day. We were on our way back from Kenya working on a project, and it was the first true vision that I developed, and I think for Sheila too, about how we could engage Rotarians in the subject of cervical cancer prevention. And so I just want to, and I think Melissa in her talk actually mentioned this. Her team uses people who are not doctors, they're not clinicians, yet her team needs people like me with low skills and high energy that are willing to learn a simple task and help them put on their effort. So my point is that this cervical cancer prevention work is an activity that every Rotarian can get engaged in, and they can make some wonderful relationships out of that. And I just want to highlight that. Now, before I sign off, is there anybody that has any questions that need answered now? I see James has, and so James, you can unmute yourself and James, sadly, I can't hear you. James, it's really funny. We heard you quite well before the meeting, and well, here we are, and now we can't. And I don't know how to fix that problem. So can anybody hear James?
No.
No. Mm-mm.
So James, I'm sorry, but perhaps you'll send an email to me and I'll include whatever you have in the follow-up. Sorry, we can't hear you. And I don't know why that is. I see you're unmuted and yet here we are. Well, look,
Carl.
Wally Temple,
Hi,
this is my friend from Calgary.
Yeah, thank you. What a wonderful presentations. And I've sent some questions on my chat, which you might just read, or I can tell you what they are. First of all, I'd like to ask why we chose 4 per 100,000 as the target, because that still means 120,000 women in the world will get it and 60,000 will die. So it's a big improvement, but why are we not choosing a lower number? The second question I have is, we have just got a grant from Rotary International for Guatemala, and I need 9 units. And we're paying about $1,900 for each unit. I'm wondering, one of our presenters said $1,500, and I'm just wondering if how we can get a reduced price for our Rotary project. So those are my 2 questions, but I'd just like to say the presenters were inspiring, and it's very exciting to hear from them. Thank you for, I would like to mirror Carl's comments that thanking the presenters for their tremendous presentation today.
Thank you, Wally. Actually, I'll just comment briefly on the 4 per 100,000. And I am, by the way, probably not fully informed about this, but as I've participated in discussions throughout the past few years, I believe that the world has seen Australia as being the gold standard for what can be achieved, and that is their number. And so, as far as I know, that's how it was developed, but I agree with you. Why not make it better? And I will try to also get you information on the thermocoagulator that is, try and create a connection there for you. And maybe there'll be an opportunity for you to do a little better with your pricing.
Fantastic. Thank you.
James, did you fix your problem?
I think I have. You can hear me, I hope.
We can hear you now. Sound like a Verizon commercial.
I'm sorry, I might repeat myself, but I'm unfortunately not medical. I'm a civil engineer, but I got this job in our district simply because our club did a very successful palliative care project at Baragwanath Hospital. So I was asked to join the district committee and handle this side of it. I think the one question I would just like to ask, is there anyone who has direct knowledge of what is going on in this field in the countries which are in our district? That is Botswana, obviously South Africa, Eswatini, that's Swaziland, and Mozambique. If anyone has any direct knowledge of what is happening there or what initiatives might be in place, I really would appreciate it, because that's one of the things I've been asked to do, is try and link across those countries so that we all can have, a district-wide initiative rather than a country-wide initiative. So that's probably my main question at the moment. Others have been answered in a way during the presentation, which I found absolutely phenomenal. I really have learned more in the last hour than I have in the last year. So I think it certainly leads us on. And I'm not sure whether Richard would like to say something, but Richard knows a heck of a lot more about this than I do. I'm therefore very pleased that he's taken over my position in the club. But I thank everyone for this. I really appreciate the amount of information which was shared today. Thank you very much, Carl.
Well, James, I see Sharon Kampabwe is from the World Health Organization is on this meeting. And so she probably heard your question. I'll follow up with a message to her and see if we can find some information for you. She's very likely a good resource, or knows who is. She's a wonderful lady, by the way. Sheila Hurst and I have had a chance to spend some time with her on a number of occasions, and her dedication to this work is just inspirational. We've really run past our time, and one of the things I've learned in my Rotary meeting stuff is that you start on time and you end on time, and that keeps your audience willing to come back. So I would like to thank you all for your participation. You have my email address if you feel you need to share something with me. I'll try to, actually our goal is to get a recording of this session up on the HURAG website. I hope that turns out well. Anyhow, thank you all very much and have a wonderful day.
Thank you.